up your all the lacunae and your examination, the coverage of the topics would be in proper time. So what do you say, Dr. Sanand and Dr. Manjunath? This time the examination is slightly like, no, there is only 10 weeks before the registration date and the exam date. Any viewpoint?
Yeah, they'll have an advantage, one thing, and they can actually kind of plan it in a better way.
Yeah. And I will be taking the people who would be the first one to plunge into this examination preparation. They will be in a very advantageous position if somebody will be joining late and somebody will be like, starting it very early. Okay. So if everybody agrees, so can we start? It is 7:07.
Yes, Tapas, go ahead,
Yeah,
please.
okay. So happy day to everyone, and we are here from 360 Critical Care. Welcome, dear friends from different parts of the world, and Merry Christmas and Happy New Year in advance. To start with, it's festival time. So also for the 360 Critical Care, we all know that you are all very brilliant people, and you have all uh, had a good training in your critical care days, and also now you are aiming for the most, I would say, the examination which has already been dreamed about, that is EDIC 2. So you have been practicing the critical care as well as appearing many exams in the maybe last couple of years, but this exam is slightly different. Myself, Dr. Tapas Kumar Sahu, one of the course faculty and the course director, along with Dr. Sanand and Dr. Manjunath. Dr. Sanand is from Australia, my colleague, who would be discussing also later on. Dr. Manjunath is my faculty and he is also my colleague since long time, and we are all working together. Dr. Jitendra, who is also a very dear friend and colleague, so he will be also joining very soon. He's working in Apollo Hospital, Bangalore. Dr. Manjunath is working in Manipal Hospital, Bangalore, and Dr. Sanand, as I have told, he is working in Australia. And myself, I am working in Medanta Hospital, Ranchi, India. Now, we all have aimed and also dreamed about EDIC 2, but it's not that easy. But definitely with the proper preparation, and if you are really on your like the target from the day one, definitely it's worth. Now, there are certain well-proven points we always start with in our introductory class, that critical care medicine is now a super specialty in many of the countries, and this is currently continuously evolving, and the examination process, examination format is also continuously evolving. But to pass it successfully needs focus, strategy, and practice. The EDIC examination, which is our current perspective as well as purview, European Diploma of Intensive Care Examination, this is more comprehensive and definitely need proper planning to appear and pass. And it has to be guided and start early for success. Now, we do not have the previous, what I can say, the stamina when in our MBBS days, in our medical school days, to do all the exclusive preparation on our own because of the workload, the volume of patients in our hospital. There is no structured course format for critical care, which is a super specialty nowadays. There is very heterogeneous academics. We have everything in the internet. We are like, no, I would say overloaded with information. But what is to be followed up in the very limited time before the examination, and that also a very pricey exam, very, I would say, prestigious exam like EDIC 2. Now, we do not know what to read, and moreover, we all have experienced that we do not know what not to read, which is sometimes more important or crucial than what to read. We have many things apart from the academics now, because we are all like having our family, our personal life, our like the clinical work, and no one right now is there to guide and teach us to make us more smart, or like I would say learning professionally. So definitely we need to have someone to help us to start preparing as well as clear it also successfully. Now here we are there to help you. Now the advice, the help, the tips, the support, the assistance, and the guidance. We have started this academy, which is named as 360 Critical Care, almost 2.5 years back. And this is, I think, the sixth batch which is right now going for the examination in the May 2025. And to like our own, I would say, the successful venture, this is something which is proving to be boon for the people who are preparing for the EDIC 2 as well as EDIC 1 and different other exams. But the disclaimer for our side is this is not an official presentation from ESICM. Whatever views we are putting forth in this presentation by me or by Dr. Manjunath or Dr. Sanant is based on our own experiences as trainee, then as the teacher, as like the practitioners over the years while preparing for the exams and also teaching. The candidates who are preparing for the exams are free to follow his or her own path, brain, and heart. This webinar is being conducted to give you an overview for the candidates who intend to write the EDIC exam. As it is part 2, we are also having part 1 exam which has already been started, and there are like almost 25 candidates have joined within span of 10 days only. And these are some of the webinars which is creating interest among the examinees who are planning also in subsequent exams also, not only in the May but also in the November session, in a better systematic way to clear them. Now, just a brief idea, what is this EDIC exam? So EDIC exam is European Diploma of Intensive Care exam conducted by European Society of Intensive Care Medicine. It's a very prestigious society, and we all know the EDIC examinations are set out in two parts. Part 1, which is the written exam, MCQ based exam, which you have already cleared, and the part 2, which is right now for all of us is enigma, that how that exam will be held, how the questions will be coming, how I will be uh, like passing it successfully both in the oral and the clinical case exam. Now, this exam is conducted twice every year as spring and autumn session. Now, the basic purpose of EDIC is to seek the standardization of the education and training of quality intensive care across Europe. It started from Europe, but now all over the world, many countries accept this as one of the finest examination and also the diploma to get in. Now, EDIC exams, every year, the examination format, the process, the questions that are meticulously developed and continuously updated to create standard exit exams, and this accurately reflect clearly defined the goals, the necessary skills, the attitude, the competency, and also the knowledge that is required for intensive care practice as a qualified consultant or attending. Now, the acceptance of EDIC is like it's a key component of ESICM's education strategy, and it aims to set a standard for entry into intensive care specialist practice in Europe. So this is something, again, this was like announced in the year 2021 that once if you are practicing in some other country, not in Europe also, if you are having EDIC and you have passed it after 2015, so you can get the license to practice in Europe. Now, this is something which has the attest to its widening acceptance all over the world. Now, coming to the proper the objective of today's webinar, how to start preparing for your EDIC exam. The first and foremost thing is you have to visit the site esism.org website, create your account and complete your EDIC profile. Be ready to go for the registration once the date will be there, like which will be announced and which is already there in the site. And we normally recommend you to become member of the ESICM, which is renewed annually. Maybe you will not be interested to continue that, but for the examination sake, it is better to be member, where you will be getting not only the registration of the examination in a little bit concession price, rather you will also get access to the ACE modules or the ESICM Academy, which is the academic the framework of the ESICM, and you will get many discounts for the ESICM conferences as well as some of the other preparatory course fees. Now, if you have already applied for EDIC 1 or like you have cleared it, now it is time to pull up your socks and you have to be really serious to go for this EDIC part 2. Though the registration has not been done, but if someone is thinking about it, don't delay further, because every year, every session, the examination is getting tougher and tougher. What we could get from the feedback of our candidates or the trainees who are part of our courses. Now, this is the current update that the spring 2025 examination for part 2 is on 20th and 21st May 2025, and the registration will be on for the part 2 is February 4, 2025. So this is the current update. Just block your calendar, and you have to be really on your toes on February 4th to get the first, I can say, the ticket to the examination, that getting a seat. And then you have to again block your calendar for 20 and 21st May if you are appearing the exam in the spring 2025. Now, coming to the EDIC part 2, I will be very short and crisp for the format of part 2. And this is again continuously evolving. So I discussed today with one of our successful candidate to get the exact what happened this time, how the examination format was in the November 2024. Now, part 2 exams are different from part 1, being the oral or the clinical based exam that we all know. Now, the part 2 exam is following the model of OSCE, which is objective structured clinical examination. And this is derived from the competencies listed in the Preparatory syllabus that is there in our ESISM website itself. On that basis, they have a structured the domains that has to be covered to get the successful completion of this diploma. So based on that, you have to read and you have to go in detail to each of the the domain. Now you have to visit this link if you want to know about details about the Cobatry system. Now for examination guidelines and regulation, definitely there is a ESISM website link which is updated every, I would say, the session. So you need to follow up with the examination format. Now this is the thing that has happened, or that was the format in the November 2024. There were 4 clinical case scenarios, because it would be CCS and CBS. So 2 were long case and 2 were short case, so that you will be automatically get to know in the CCS examination. The day will be different. The first day would be CBS, the second day would be CCS, something like that. So it can be divided on the basis of their own division, and they will be distributing the stations also to the individual candidates. You will get the emails beforehand. Now there would be 3 computer-based stations, CBS, which includes biochemistry, images, curves, and graphs. Now, you have to compulsorily pass the CCS and CBS sections to clear the exam. So it cannot happen in the CCS you are completely fail, and in the CBS you are 90% and you will be passing the EDIC 2 exam completely. No. Now, the clinical case scenarios, the first and foremost, these are real cases managed in European ICUs. So they should not be copy pasted from some or other books or some or other the imaginary clinical cases. In the online format of the exams, that is the CCS, you will be given the first clinical vignette of that CCS case at least 10 minutes in advance. So for the first clinical vignette, you will get 10 minutes. After that, you will not get this type of the 10 minutes time duration. Rather, it would be quick. So you will be getting the clinical vignette 2, the clinical vignette 3, 4, so on and so forth. Now, you have to go through the first clinical vignette, then the questions will be asked on that case, and there will be following more vignettes on the same case for the next 17 to 20 minutes. So this is something I got the information from one of our candidates. Before it was around 25 minutes. So they would be, previously there were 3 CCS. Now they have made it 2 long case and 2 short case. So little bit of more cases number. But yes, the time duration for each CCS is right now reduced from 25 minutes to around 20 minutes. Now, answers to the vignettes carry 1 point each. The more you answer as per their grid, you will get more marks. Now, Usually, this is our observation. Again, CCS would be covering surgical case, medical case, and some or other subspecialty case like neuro, cardiac, etc. Now, having said that, in the first 10 minutes time, you get preparation for the case to start, the discussion or the questions to start. Now, some of the clues that you can take from this webinar is think about the questions they might ask. Beforehand, maybe around 8 years back, there were no online CCS and CBS. So there you were getting the questions in the hard copies. But as right now you are getting it in your screen, and the proctor is looking at you continuously. So you have to just analyze it from the screen. What is there in your screen? The first clinical vignette. Now, some of the common questions that the examiner might want to ask you, or the question should be there: summarize the case. Now, every question would be expected to have 4 to 5 answers. So you have to be really brief and to the point. You cannot explain it just like a theory question, and you cannot be also so short that the answers would be actually incomplete, or it would be difficult to understand what you are actually trying to convey. Now, they most likely want to hear about the organ dysfunctions or the history. From history, how you are actually corroborating the clinical findings to reach at one provisional diagnosis or differential diagnosis, and what is your immediate management, as it is a critical care exam. So they will not go into detail about the examination and your observation, something like that. Rather, they would be more pertinent towards the immediate management. What are the further investigations that you want to immediately advise, and what can be cause of some or other complications that has happened in the first day, second day, something like that. Now, if we are continuing with that, then the case would be evolving. And we have most of the time have seen that a cardiothoracic case, a post-operative cardiac surgery case, immediately on day 2, they would be changing it to have a complication where the patient is having intracranial hemorrhage or something or other related to some other organ rather than the proper cardiothoracic or the cardiology. So you will be giving new investigation results like CT scan of the brain, MRI of the brain, X-ray, something like that, to focus your diagnosis, how we are actually from one system immediately changing to the other system to tackle that case. Now, there are certain further questions also. They can ask you related to 1 or 2 questions related to the pathophysiology, some or other evidence. Then there would be some or other the counseling or communication, breaking the bad news. There, your patient may be on the clinical vignette 3. After everything you have done, patient may be having cardiac arrest. Then how you are managing the post cardiac arrest status of that patient. So at the end, they would be expecting, as you are the consultant or you are going to be the consultant in your ICU in your country, how you are tackling some of the difficult things in our ICU, like end of life care, brain death determination, and organ donation. So these are the format normally they adopt when they are going for the CCS. Now, coming to the CBS, the other part, it is having 3 stations. Very clear ECG curves and graphs would be in the station 1. CBS 2 would be radiology, and CBS 3 would be ABG and biochemistry. Now, there would be almost 10 to 12 questions, 10 to 12 minutes. Just easy to remember. If you are taking more than 1 minute per question, so definitely you are in trouble, or you are going to be in trouble. You would definitely at the end lose 2 to 3 questions because the time limit is fixed. So you may be quick to answer the questions, or you can skip the question, go to the next question. So it cannot happen that you would be taking 5 minutes to answer the first question, and then you will be expecting that the next 8 question would be easy enough. No, so it's a little bit difficult. So that's why CBS is, as per our understanding and the feedbacks that we have got from our candidates over years, that this is probably the most difficult ones because of the time constraint and tricky how you are going to answer. It should not be long enough and it should not be so short enough that the answers would not be actually conveyed to the examiner properly. Now, all the cases come with a brief clinical information, and many times, as we have observed, that the answer, the clue, is in the image or in the first two lines of the case that have been provided to you in the screen. So read the clinical vignette fast, but your reflexes have to be really sharp. Now, the curves and graphs, I'm not going into detail because we are coming up with one or two free webinars more before our proper course. So the curves or graphs can come from the variety of ECG, ventilator graphics, CBP curves, IABP, ICP. Nowadays, the trend, the last two times we are getting that the examiners are getting CRRT, the troubleshooting curves also. So something which is rarely you need to be thorough with. ECMO also, they are coming up with all the questions related to ECMO. So do your Google, try to practice at work. You will not get everything in any course. So you have to think about that this can be a question, and in the examination you will be surprised to know that many times if you are actually framing your questions also, you are preparing your questions also during your clinical training, some of the questions should be asked in the examination. So try to take help also from your colleagues to get some good images from their own clinical practice. Radiology, it can come from all types of CT, abdominal X-ray, ultrasound, echo, focus, but MRIs are right now, they are not giving these questions as per our the candidates feedback. So all these imaging except MRI. Now, quite a range of topics, but we normally suggest to our candidates to adapt or refer to some of the internet where they will be getting like radiopedia.org, life in the first lane. I will be giving you those names where you will be getting at least enough of these images as well as curves and graphs. Now, how to prepare? Almost similar. You have to start preparing from where you have actually left for the part one exam, and the minimum 4 months is required. That's why we recommend that you should join in the month of January, so that January, February, March, April, and as we normally recommend, before your final exam you should have 1 month where you will be appearing at least 3 mock tests, where you will be practicing how to answer, how to convey your answers in the correct format and also in the shortest possible time. Now, all these things, the textbooks, the resources, I think my colleagues would be highlighting those things, but more or less it would be like you are a consultant, you are going to be a consultant. So what is expected as soon as the sickest patient enters to your emergency department, then trolley to your ICU, and now you are there who will be handling the case. So what would be your approach? The examiner exactly wants to know that how confident you are at the bedside as a matured intensivist, which are dealing with this type of sick patients day in and day out. So we recommend that whatever right now you are getting in next 3 to 4 months in your clinical practice, in your respective ICUs, try to interpret those things and collect those data, the graphs in your maybe if you are using in tabs or iPad or the laptops, and if you are having you can write it also, make your own question bank. So we have experience that those people who try to visualize that anything coming in their clinical practice as a question, so that would be more easy to correlate and your reflexes would be also brisker. Now, how to prepare? So these are something what our the previous candidates have recommended, that self assessments and attending a course, and also be updated with the trials, recent publications, some of the European guidelines. Then prepare your notes, handwritten or iPad or tabs that I have already mentioned. For the last minute revisions, there are enough textbooks in the market, but you at this point of time we do not know that how you have been reading in your core training period, but we do not recommend that if you have not started any textbook or you have not read in your training period, do not like take this type of bulky books where you'll be confused what to read, what not to read. Rather, The question format is very specific, and they expect that you have to be thorough with your clinical case analysis and also interpreting the curves, graphs, ECGs, and images. So these are some of the textbooks. If you have it, it's well and good. Or if it is you have not read it, rather you should be entering into a proper or like the formatted and also like the preparatory course. And you can also refer to some of these internet resources like Life in the First Lane, MCRIT, Deranged Physiology. You can refer to up to date ISU one pager, so on and so forth. And some of the specific OSCE books, like this is from the Australia. This is a data interpretation by Dr. Venkatesh. OSCEs from the UK. So these are something which would be making you a little bit of practicing these questions more often. That is the only advantage, and you will be not having a fear of getting new questions each time. So with this, I hope everybody who is dreaming about this European diploma, they would be having their name inked in this blank space. I have actually categorically made this colorful so that the candidate who has successfully passed it's actually hidden, and you will be having your name you can dream about, and you will get this certificate from ESICM. So thank you very much. And we are coming up with our course. I am just sharing the date. This is the flyer I am actually right now only releasing to all of you. The course starts from 11th January, and we are having like our faculties prepping up with all the examination materials, the modules from now only for starting to help you to successfully clear EDIC 2 exam, which is upcoming. And this is something we will be sharing this at the end in the group. So how we have divided from 11th January, it starts, and how we are ending up with all the domains, the 12 domains, and then 3 mock tests, which are again one of the, I would say, highlight thing about our course, where you will be getting live one-to-one examiner examinee interaction, just like in the real exam simulation. Thank you very much for your patient listening, and I am handing over my the discussion to Dr. Manjunath and Dr. Sanant, and also Dr. Jitendra.
Suppose
So
thank
any
you
of
for that introduction that you do every time so well. I think you have
thank you.
pointed out most of the important aspects of the exam and what is the expectation as a candidate to prepare for the exam. I think this exam has evolved over the last 10 years, and more so over the last 2 years that we have seen, or 3 years, I will say. The type of question, the level of what do you say, intricacy required for the answers have gone up also. We have modified our course accordingly. Each time we try to add up few more things into it that will be helpful to you guys also. But as Tapas was saying, the practice is the most important thing. You have to look, or you should be looking at things that you face every day, like seeing a blood gas report or seeing a coagulation report or seeing a anti-micro or antibiogram. So, and interpreting in an exam sense is most important, even in ECG also. So you have to be on your toes for next 3 months to put those things as exam practice, because as suppose was saying, 1 minute, that's what you get for the CBS questions. Um, any one of us can interpret an ECG if we are given 5 minutes correctly, but in that 1 minute you have to count for make it count for your exam. So that is the most important thing. Practice is the main part of it. Now I'll invite Dr. Manjunath and Dr.
Yeah,
Jitendra to add few things into it.
Yeah, hi. Thanks, Anant. Thanks, Apat. I think it was a wonderful session of giving, I think, for the part two, how to prepare and all that. So, but I think we are with the sixth batch now. So, but so what I would the suggest or advice for all the students is, and you need persistent and dedication here. It's not that you sit like a 1 month and before the exam attend the like mock exams and give the exam. No, it's not like that. So this the part two, the preparation is entirely different. It is not like you sit with the book and study. It is like daily the practice in intensive care in it, and whatever you do, and you should consider that patient assessment and you're going to do it is like an exam for you. Start with ABG, start with a ventilator, all graphics and radiology images, X-ray, CT scan, all that. If you start doing the practice in your daily working hours, and it will be easy for you in the exam. And also, and if you join this course, I would expect all of you to take the mock exams before the debriefing and attend all the debriefing. If you don't have that or dedication and commitment, you cannot succeed. And it's your responsibility that you have taken the exam, and you should make sure that you succeed in this exam. So, and attend all the modules and revise all the video or debrief and videos. And next 4 to 5 months, it's all your hard work. If you do hard work and put effort, and you will have one more feather on your cap, and it's EDIC. So that's all I can say for now. And I think Tapas, and we have our previous batch,
Yes,
the
yes.
successful and the candidates.
Yeah. So thank you, Dr. Sanand and Dr. Manjunath. So now we have two successful candidates in our last the preparatory course. Dr. B. Mohan is there. He is a bright example of how perseverance pays at the end, and he just I would say didn't leave any stone unturned to get the EDIC part 2. So over to you, Dr. B. Mohan. Thank you very much for joining in very short notice. And please share some of the tips and tricks to the upcoming batch and also the trainees who are dreaming about EDIC part 2. Dr. B. Mohan.
Am I audible now?
Yes, Dr. B. Mohan.
Okay.
Welcome. Yeah.
So, good evening. EDIC part 2 is not the test of your knowledge. It's the test of your reflexes. So, there will be about 75, 80 topics we have to continuously revise. So, one of the best aspect of TRICS is that you schedule your plan as per the schedule of TRICS, so that by the end of March or early part of April, will be finishing most of the topics. That is point number one. Point number two, when you study certain topics, you should consult the radiology part simultaneously. So, for example, you are reading about the traumatic brain injury patient. So, you should read about the CT scans, EEG, and all those things. So that will save your time during the last part when you have to revise things. Otherwise, you will be running here and there for radiology part. So your radiology part should finish along with your topics. So that is my second advice. Third advice is, when you are reading the question, at the same time, apart from reading the question, you should know what all things the examiner is going to ask me in this topic. So you are mentally prepared even before the examiner asks you one first question. And the last point I will say is that the examiners are concerned about asking a specific answer. Say, for example, if they give you a case of inferior wall MI and the lead 2, lead 3, and lead AVF is showing ST elevation, they will say, what is the next investigation they will do? And the next investigation is you have to do right-sided leads. If you don't answer this question in this way, you will fail. So the questions are from very expected topics. See, we have only 5 or 6 major organ systems: the brain, the heart, lung, kidney, liver, and involvement of multi-system or involvements. So you should have reflexes and a good algorithm in your brain to answer simultaneously, so that you don't waste time on thinking there, because they are reflex questions. Last point I will say that one thing which is different in their setup compared to us is that they go for very early CRRT. What we do here is that we wait for KDIGO criteria 3, I mean stage 3 to reach before we start CRRT. But there, the CRRT is in the early stage. Don't hesitate in saying that I will start CRRT in a patient if you have few indications of, say, for example, patient is having severe metabolic acidosis or decrease in output. So they start CRRT very early. So that you have to keep in mind in answering the question. And if you have resuscitated the patient, they will invariably ask about de-resuscitation. So certain concepts has to be there. And simultaneously, you read about ventilator curves, ABGs. And for that, my advice to you is that go along with what TRICS guys are doing. So if they are saying respiratory, so in that 10 days, try to finish most of the aspect of respiratory part, then it will be very easy for you during the exam time. That's the only thing I will say.
Thank you, Dr. Bimohan. You have actually made our job easier by like highlighting what is actually expected from the candidate during the next 4 months. Thank you very much. All the best for your
Yeah.
future life. Yeah.
Thank you. Thank you. Thank you. Thank you.
Now I welcome Dr. Nasreen to please share your experience as well as tips and tricks for the candidates.
Thank you, sir. So from this tricks course, what I have felt is like we have to attend all the modules in time. We have to attend all the mock exam. Each system has mock exam. So once we do all the questions and when we attend the live videos, we get to know more. When you guys discuss about the questions and all, we can answer, and this is what we have to do with each modules. This is very important thing, and what I have got other tips from this courses, like Tapas sir always says that we have to maintain that composure. This is very important thing, because just before the exam, when we are so much in stress, when we even if we know the answers, we might not be able to. So if we maintain our composure throughout, I think that is one of the thing which we have to keep in our mind. That is what I have learned. These are the tips and tricks which we get from these courses. And it's very important to attend such a course, because this course covers all the systems in detail, and all the teachers are good in their own way. Like we learn from each and every teachers many things, like from ethics, everything. All the topics are very important. And one at the end of the course, we will get to know how to answer in a EDIC exam. That structure we will get. And those 3 mock exams are also very good. We have to develop that structure of answering the questions, that we get only by attending all these modules and the mock exams. So that's the best thing about this course. I really recommend this course. It really helped me a lot.
Thank you, Dr. Nasrina, for sharing your own felt tips and tricks to the candidates, and thank you for joining. Best wishes for your future endeavors.
Thank you so much, sir.
Now I welcome Dr. Noel Fernando from London, and he's working in Princess Alexandra Hospital. So despite the time zone difference, he joined. So Dr. Noel, please share your own experience as well as the tips and tricks.
Yeah, hi everyone. I'm Noel Fernando, one of the intensivists from London. First of all, welcome you all for this course, and I'm pretty sure you're all going to enjoy this course. First of all, I need to tell you that I was a bit late in joining this course. I just joined only the last 1 month, to be honest. And with the busy schedule of working, this briefing, like every system, they've divided into each system, and each system they've got a lot of articles, very useful for the course. So very useful for me looking into going. I didn't attend it online, but I was fortunate enough to see the videos later, and it was so good that I was able to brush up my knowledge and refresh my skills over the for the exams as well. Um, I then felt like I should have joined this course earlier, because I would have enjoyed the course, because the way they run the course, it was like more it's like a pre-planned session. They've got each system for each month and a week. They give some questions for you to prepare and answer, and then you get some feedback on it, and then you are personally given some feedback how to answer those questions. It was so well organized. and it was pretty much very useful for me. But please don't join as a last minute. Join early. Join from the first session. I actually, at some point, I thought, you know what, if I fail this exam, I should join from the start again in the course, because just for the sake of enjoying the course, I thought of joining it again. But like luckily I passed. But I am telling you honestly, all the four, like the faculties, I really enjoyed the debriefing. My favorite is Dr. Manjunath. His debriefing was awesome. It was more. I really liked it. I don't know, for some reason I liked it. I've seen his debriefing at least twice or three times before I went for the exam, and each and everything they discuss in this course or your exam questions. I can tell you that for sure. And it was so helpful. I didn't even touch my books back. All the debrief videos, all the small CBS and CCS, I just looked upon and went for the exam. I was so confident. I was able to answer very clearly. I would definitely ask everyone to attend all the sessions. Don't miss it, and especially the mock exam. That gave me a little bit of, because when I came for the mock exam, the first mock exam I didn't. I think I did bit average, but second mock exam I was very confident enough to go. And mock exam is ultimatum. That is the final pre-preparation for the exam. But this course, I think it's quite useful for everyone, and I think they should expand it. And um, uh, this is not only for the exam perspective, but also for the day-to-day practice. It will be very useful. Thank you.
Thank you, Dr. Noel. Anything from Dr. Manjunath?
Thank you, Noel.
Your
No,
favorite student.
I just got very attracted to Manjunath's debriefing.
Yeah.
I don't know, for some way, I have seen his videos at least 3-4 times. So
Oh,
I become fan of you.
thank you. Glad to hear that.
Thank you, Dr.
Thank you.
Manjunath
Thanks.
and Dr. Noel, for this type of effort. And Dr. Noel, all the best for your future endeavor. We would
Thank you.
definitely wish to have you also in some of our sessions as
Sure.
faculty. Yeah.
Sure.
Thank
Thank
you.
you. Thank you. Bye.
Thank you.
So
Thank you.
now, anyone at this point of time, any attendee who wants to share anything, they can post in the chat box, or else I would be now requesting Dr. Manjunath to discuss about one CCS and around 7, 8, or 10 questions in the CBS, so that you will get a glimpse how the EDIC part 2 normally happens. Anything? Anyone who wants to share or have any query? In the meantime, Dr. Manjunath is sharing the screen. Okay. So, Dr. Manjunath, it's all
Yeah.
yours.
Yes. Yeah. So I'll start with the CBS first, the CCS first. Yeah, see the
Yeah,
scene.
perfect.
The scene. I'm audible, right?
Yeah, yes, you are audible.
Screen.
Yes.
Yeah, fine. So see on the scenarios on what to get in the exam, it is like the scenarios like what they say in their ICUs, and you don't get under straightforward under respiratory failure, and you don't get any straightforward the cardiogenic shock. It will be a mix of each and everything. Okay, so and all four vignettes, and they make sure that it will cover every system from head to toe. Okay, so and we'll have this in the scenario here. So we have a patient who is a 62-year-old like female, shifted to ICU with a shortness of breath since the last 1 hour. She was admitted for the fracture on the left proximal tibia, for which an ORF is like planned. She's a known case of diabetes on OHA since the last 6 hours. On arrival, and she is actually tachycardic, afebrile. Blood pressure is like borderline 102 by 56, and SpO2 95% on high flow nasal cannula. It means, and she's hypoxic and conscious oriented and tachypnic. So as soon as you see the vignette, please pick up the most important points. So which are the most important points here is shortness of breath. She's got a fracture. She's a tachycardic, tachypnic, and hypoxic. So then comes, what are your differential diagnosis here? So because and she has got a fracture and hypoxia, I would consider and fat embolism syndrome, and then what pulmonary embolism and the pulmonary edema. And if you see, considering the diabetes in the like a background, looking at the X-ray here, so I would also think of on the community acquired pneumonia and the aspiration as well. So what's your immediate the line of treatment? Always, whenever they ask you the management, immediate line of treatment, like start with A, B, C. So airway, breathing, the circulation. So, and 1 second. Yeah. So first is airway, breathing, and the circulation. So now then you'll see for under securing the under cannulas, IV fluids, empirical antibiotics, and in this patient, and you will also consider for anticoagulation. And what all the investigations and you would like to send. So always come with the general investigations and the specific investigation. So we'll go ahead 1 second. Yeah. So whenever and you get a scenario of anything under related to under cardiac or respiratory or the CNS, and you should have a syndromic approach here. If you have a differentials like a patient is encephalopathic or unconscious, or the patient has got a like weakness, or the patient has actually presented with a seizure, you should prepare in such a way that and you already have differential diagnosis in your on the thought process, and all that you should actually vomit in the exam as soon as they start their vignettes. Okay, if the patient has got a shock and if there is any visible and the bleeding is going on, so start with what all the types of the shock and all that and how to approach it. And if the patient has got a hypoxia, pneumonia, so then how to approach it. And the patient has got a anuria, oliguria, how to approach it. So, and you should have a syndromic approach for all. If you have a patient with encephalopathy or unconsciousness, the first thing you should think is whether it's a central or a peripheral. In the central, whether it's non-infective or infective. And then if it is peripheral, the same, infective or non-infective. If the patient has got a weakness or critical illness or anything, it's a GBS or a myasthenia gravis or anything, central, spinal, peripheral, muscular, and others. Uh, and the seizure, then again, it is central or peripheral, or any drug induced or central. If the patient had any intracranial bleed or any stroke, the following had a seizure, or any mainly intracranial and mass as well. So, and your approach in the exam should be the most of the time, the first question will be, what are the differential diagnosis like for this scenario? If the patient has come with these kind of and the syndromes, and your approach should be in the same way that the first three differential diagnosis should be almost specific to the syndromes, the symptoms, and also the collaborative all vitals and whatever they've given. And then you come with all the other and the rarest differential diagnosis, because and your marks also will are distributed in the same way there in the exam. So the shock again, and you should always divide it's a cardiogenic, it's a hypovolemic, or distributive, or obstructive. How do you diagnose all four of them? Okay, and you will have, see, the most of the time, according to us, 90% of the time, all the tips of these answers, it will be there in the scenario. But you should make sure that you you recognize it and then collaborate with all the investigations and the vitals, and then give the answer. So first comes the cardiogenic, whether it's a well, infective or non-infective. Infective, the myocarditis or the septic cardiomyopathy, and the non-infective, it can be anything, the vascular, drug-induced arrhythmias or mechanical obstruction. So then hypovolemic, hemorrhagic or non-hemorrhagic. If there is because of the blood loss or because of any non-hemorrhagic causes. And the distributive, again, it is on the septic, anaphylactic, or neurogenic, or drugs and toxin induced. And then comes obstructive, it is all pulmonary or mechanical. So hypoxia, yeah. So then you should always see whether it is the which part of the hypoxic drive has got affected, whether it is ventilation, perfusion, the mismatch, or the mainly the right to left shunt, or because of the reduced inspiratory oxygen or hypoventilation, diffusion defect, increase oxygen extraction. See, all this, and we are telling because, and you should know, depending on the scenario, how exactly you divide them into these all causes of the hypoxia. Okay, and then comes acute kidney injury or renal failure, the pre-renal and the renal and the post-renal. As soon as you see the scenario and then you see the investigations, you should actually divide them into like pre-renal or renal and post-renal. So, and your approach for the differential diagnosis to get the differential diagnosis and also for a specific all diagnosis, and you should be aware of all this. So then what investigations and will you advise? Again, starts with a complete blood count, RFT, DDEM. For our scenario here, the old lady who has come with the tibia fracture, the CRP, the PCT, imaging, Doppler ultrasound, echo, others like and the ECG. So the bedside ECG and echo was done. It showed some on the sinus and tachycardia, the mildly dilated RARV, good LV systolic function. What will be the next investigation? Because of the mildly dilated RA and RV, I would like to go with and the CTPA. So the CTPA was done. It has not shown any features of pulmonary embolism. So with this, and but you can see the bilateral pulmonary infiltrates, which actually we suggest you of some kind of or lung infarcts as well. So all this actually, all these investigations and whatever you have done is all suggestive for the fat embolism syndrome. So how do you do the investigation and the format? Investigation, the format, whenever they ask you what all the investigations you send for, the first comes the blood investigation. So then think of any infections, then the imaging. So then other specific test for that specific diagnosis. Okay, the blood test is all on the CBS and the system wise, the liver function test and the renal function test and the coagulation test, and then comes anything with the cardiac and the tropi. And the cultures, the mainly infection part, blood and urine culture and sputum culture, viral PCR and all that. And the imaging, ultrasound, echo, CT scan, MRI, all that, and a specific test as well. So then, what are the criteria for the fat embolism syndrome? And you should be aware of the names of criteria and also what exactly it has, major and the minor criteria, at least among three, and you should know two of them. GERD's major and minor criteria and the Schonfield's and the scoring system as well. The following that, then they'll ask you give the definitive and the treatment plan because the patient has got hypoxia. So your answer should be I would treat hypoxia with oxygen and aiming up to the target and the saturation of like more than 94. I would do with all NIV support, HFNC and all that. And then comes early fixation of on the fracture. Treat the symptoms and also look at the source of it and heparin. And the steroids has got some the controversial role. It's not indicated in all the patients. And they might ask you name two precipitating in the factors for the fat embolism apart from the trauma. It is the most commonly it is seen with all with the sickle cell disease and also with acute pancreatitis and sometimes with the TPN as well because of the fat droplets and also a liposuction, the patients who undergo a liposuction. So what is the clinical triad of the fat embolism, the dyspnea, confusion, and the petechial rash? Guys, if you have the scenario with a petechial rash and confusion and dyspnea, please be aware that and your thought process should go towards the fat embolism. So for that, and you should actually do in the practice and repeatedly of these in the scenarios. So the mock on the second, the vignette 2 of the same patient, day 3 in the ICU, patient and remained to be hypoxic and hemodynamically stable. She was on the subcutaneous heparin of 5,000 units 3 times a day. ABG looks okay, acceptable. So the lab parameters on total counts are actually raised. It's around 16,000. The platelets of around 98,000. Urea and creatinine are like borderline. D-dimer and the slightly raised. And you have HRCT here. So, and you should know how to read the HRCT, the plane, the contrast, and all that. And then you can see the fluffy opacities of all the zones, upper, middle, and the lower. predominantly lower. And the patient actually complained of the severe pain in the affected limb, which was actually not there before, and it did not under subside even after intravenous analgesics. On compared to on the limb which was tense, and there was actually decreased in the sensation of the unaffected limb, and there was no reliable pulse oximeter and the waveform. All these are actually under suggestive of compartment syndrome and cellulitis and the DVT, acute limb ischemia. So, what will be the immediate investigation? The venous and the arterial Doppler. See, and you need not be aware of all this because you do this day in and out in your all ICUs. If at all, if you see a patient who has got a the fracture and then after 2 days and if you complains of like a severe pain, the swelling, obviously, and you will ask for venous and arterial Doppler to rule out any the thrombus or DVT. Okay, so and the following that if he has under so much of pain in spite of all the analgesics, and you'll think of any compartment syndrome. Whatever you do in your practice, the make sure and you in the exam as well, and you answer the same. And you need not actually think for something extraordinary in the exam. EDIC part 2 is all about your thought process, how you keep and yourself in the exam, the cool and calm and answer. And you'll ask for like a CPK and urine analysis and urine myoglobin and the coagulation test. As Doppler was actually abnormal, ACS was provisionally diagnosed compartment syndrome. So, what all the criteria of compartment syndrome? It's clinical, the pain, paresthesia, the pallor, paralysis, significant extremity pain, tense firm compartment, all that, and passive stretch of the muscles, pain actually exacerbates. What is the delta pressure? I'm sure and you will be aware of it. So it is the diastolic blood pressure measured in the compartment. It's more of so if it is delta pressure, if it is less than 30, it also indicates that the patient actually needs immediate the surgical intervention and the fasciotomy. How do you manage compartment syndrome? The first comes the general management, the frequent and the serial examination, and remove all external pressure, and then supplementary oxygen analgesics, IV fluids, and all that. And specifically, it's all immediate and a surgical consultation. Indication is all because the compartment pressure is within 30 of a diastolic under pressure and also high clinical under suspicion. So then comes the Vignette 3. Patient becomes like more tachypnic. She was put on NIV and the lower limbs and the swelling gradually decreased with conservative management. On ICU day 5, she developed gross abdominal distension and was unable to pass stool for the preceding and the 72 hours and oliguric for the last 24 hours. So she is not able to pass stool and also she's not passing adequate amount of the urine for the last 24 hours. And you have these investigations the GCS look okay. The chest has got some bilateral and the Krebs abdomen is showing some distension, that tympanic on percussion. Last bowel open 2 days back. And the investigations, as I can see it as she has got AKI, acute kidney injury. Earlier, and the creatinine was actually 1.02. Now she's 1.98, and hypokalemia. The calcium is acceptable. PTINR is fine, and she's hypoxic with a FiO2 of around 0.6. So what I can see with all this is she is hypoxic, she has got acute kidney injury, she's tachycardic, and she has got abdominal distension. So the pathology is more in the abdomen and also with the renals. Okay, so then comes what are the causes of abdominal distension? It's colonic and the pseudo obstruction. So how will you further investigate? And you will ask for the CCT abdomen, and you will see for or dilatation of and the colons and the size of dilatation. What is a plan of management? The first comes a general. It is like I'll correct the hypokalemia, hypomagnesemia, and the stop all analgesics or any narcotics which can cause a decrease in the bowel movements like fentanyl or any of the opioids, and early ambulation, control the blood sugar. Specific is if you want to go with still with the conservative, it is all can give the neostigmine. So you might have to be careful with the neostigmine if the patient has got any bronchospasm or any the cardiac the issues like bradycardia or anything, and metoclopramide as well. And the surgical intervention, other intervention is when you decompress the bowel with upper GI tract with NG tube, with the lower GI tract with a under flatus tube, and consideration of colonic decompression if at all if it does not get relieved like with all this. What is the role of colonoscopy? Yeah, diagnostic and mainly to rule out distal obstructive lesions and also for the decompression. What the indication for the surgery in spite of doing the decompression, if it is still dilated, yeah, then it is indication for surgery. So then comes what are the biochemical abnormalities and you saw in the vignette, rise TLC, or thrombocytopenia, some mild coagulopathy and AKI. What are your actually differential diagnosis? Patient is actually stepping into like multi-organ failure with AKI and all that. So the sepsis with the MODS and bowel ischemia as well. And what are the indications of dialysis in this case? The patient has got like mild metabolic acidosis and oliguria, fluid overload in the sense the FiO2 is already like 0.6 now and hyperkalemia. So which type of the dialysis is preferred? Preferably you start with like a CRRT because hemodynamics is not altered much. The patient is already tachycardic and tachypneic, so better to go with the CRRT. So last vignette, the sled was started in view of the worsening metabolic acidosis and the hemodynamic instability. Patient was intubated in view of like a poor GCS, the probably septic or the metabolic encephalopathy. She was maintaining on the 40% oxygen with like a PEEP of 6. She was on the fentanyl infusion and urine output was only 20 ml per hour since the onset of dialysis. She was on 10 microgram per kg of or noradrenaline infusion. And ABG is okay. It's a bicarb of 18.4, the pH of like a 7.31. And in the morning rounds, the resident doctor was happy about the increased urine output in the last 2 hours. Pupils are right and the 4 mm and are sluggishly reacting to right, and on the left is around 2.5 mm. And urgent CT brain was done because there was actually change in the pupil size. So when you have the CT scan here, you can see some. So the differentiation of gray matter and white matter is not much, and the systems are actually a phase. It's more of a diffuse cerebral edema. What's your immediate management plan? So neurosurgery consultation and 3% saline as neuroprotective measures, head and elevation, hyperventilation. What are the likely causes in the sudden deterioration? Worsening hypotension or hypoxemia, all that. So, so see, we started with the initially with a patient has come with like fracture, had a like fat embolism syndrome, then had a patient had some the pneumonia, acute kidney injury, and now the patient has got a diffuse cerebral edema. So they can go from it to anywhere in their scenarios. So, but you should like make sure that and you pick up those things and answer immediately in the exam. And finally, the last vignette will be about counseling of the family. So once a family member has the outcome of their patient, how to explain. So, and you can use like the spike protocol, the setting, the perception, and the invitation, the knowledge, empathy, and also summarize the full illness of the patient and the prognosis and all that. All these are important, and it is exactly you should know how to answer that in the exam. So if at all if they ask you about the prognosis, then you might have to say, okay, I'll ask for multidisciplinary team meeting here, and I'll start with my and initially what all the symptoms the patient came, how it has actually progressed according to the age and the comorbidities. How do I assess? And if the patient has got a CLD, please use all the scores, all child pug score and all that. If the patient has got intracranial bleed, see the mainly the scoring system of the ICH. Following that, you should be be able to tell about all prognosis. So this is about all the CCS. Sorry. So we'll see the CBS as well now. Yeah. This is well, just to give some brief idea of it. So you have this X-ray. The first question is patient has got a triple vessel disease and he has undergone the CABG. The post-op, the patient was put on the mechanical circulatory assist device and identify the device. The patient is already on mechanical circulatory assist device. So what is the device? And they're asking you and to identify with respect to the chest X-ray and what is abnormality and you can see with respect to the device. It is you can see the IABP here. IABP is actually the tip is actually displaced upwards. It should not be like this. See, they might ask you sometimes with the hardwares, what all you see in this X-ray. It is like you can see the endotracheal tube, you can see all the CABG wires, and also you can see the central line or the dialysis cath and the ECG leads, all that. So you have this diagram here, so which is actually related to the research papers. Identify the image. What is the significance of the square shape? And you have a square shape here. What is the significance of this? This is mainly used for forest plot for the systematic meta-analysis. The size of this is the square is actually tells about the weight of the study. The point of the square, where exactly it is, it also tells about odds ratio. So if at all, if you take this, the forest plots are actually for the meta-analysis in the sense to combine all the studies and to get a clear data. So systematic review meta-analysis. In this, the position of the square is a point estimate of odds ratio from the null point, whether it goes on this side, favors or it is against to it. And then comes this diamond mark, which actually is a combined results of all the trials, whatever they have taken in the meta-analysis. So if it is all the results has crossed the vertical line, it is this vertical line is called a line of actually no effect. So and you should be aware of all this for the exam. So then comes and you have a CT image here. So where 78-year-old the male diabetic male who is 24 hours after an anterior resection with anastomosis for sigmoid colon shows sudden pain among the soft tissues of the right flank and the fever. Interpret the image. So what you can see all ear shadows here. So ear density collections and edema extending along the soft tissue and the subcutaneous fascia as well. So it is more of a necrotizing the fasciitis. So how do you manage this? Immediate surgical debridement of the involved tissue, antibiotics, you send for cultures like start on antibiotics, and if it is required, you can go with hyperbaric oxygen as well. So what is the scoring system for necrotizing the fasciitis? It has got Linac, the scoring system. It has got a CRP, WBC, hemoglobin, the sodium, the creatinine, glucose. See, all this actually signifies whether the patient is actually stepping into multi-organ failure or not. So whether it imbalances the kidney function, it imbalances the glycogen stores in the liver, and also the amount of infection in the blood, all that. So it tells how exactly the severity. So then comes the fourth one, the 30-year-old male with head injury was on ventilator. He was actually, one second. While withdrawing for the painful stimulus, his pupillary responses were equal, and the CT brain showed bilateral frontal contusions and the subarachnoid hemorrhage. His blood pressure was 100 by 60, SpO2 was 93% on 0.6 FiO2, temperature of 100 degree Fahrenheit, and blood sugar of around 70 milligram. And he is actually nursed with head and elevated at 45 degree. ICU doctor has decided that the patient requires a central line and has approached the wife of the patient for the informed consent. She is apprehensive about the possible complications and wanted to know if you can avoid all invasive procedure and about the alternatives. What ethical principles will you apply in this setting? No one will expect these kind of question in the exam, right? So what ethical principle will you apply in this setting? It is more of a autonomy and non-maleficent. And you should be aware of all the four principles and also their exact meaning and where do you apply all that. So then comes, and you have an image of echo here, on the 32-year-old primary gravida underwent a normal delivery but prolonged labor at 38 weeks of gestation and gave birth to a child. And the 1 hour and the later, and she complained of sudden shortness of breath, severe anxiety, chills, and vomiting. Her vitals are she is in shock, tachycardic, 92% and saturation, tachypnic as well. The 2D echo is done, which actually shows LALV here. What is a likely diagnosis? So, and you can say the postpartum cardiomyopathy, or sometimes even with fat embolism syndrome as well. I would go with like a fat embolism the syndrome because she has got a chills here and some amount of anxiety and a sudden onset of an shortness of breath. The postpartum cardiomyopathy, they'll not have on a sudden shortness at least, and they'll have for at least for like a few hours. So the chills is under something which actually gives us like a more uh, an inclination towards the fat embolism or sorry, amniotic and the fluid embolism, so with shock. And if the patient is actually or refractory to all vasopressors, what do you do with this kind of echo? And you might have to consider for VA ECMO. So, and you might think that the VA ECMO, the VV ECMO, are, they won't ask in the exam, and there are like a few of the under sessions where they have gone for VA ECMO and the VV ECMO as well, and they might ask you for the weaning, how do you initiate, how do you do the resting lung ventilation and all that. So when you have a scenario with 54-year-old previously healthy male was admitted to all ICU with 45% of burns, and within 1 hour of injury, patient is in ICU in a shock state. He was intubated and the fluid resuscitation was like started. Peripheries are pink, and the hemodynamics are worsening with a rapid rise of vasopressors. 30 minutes and the later an ABG is done, the pH of like 7.25, PaO2 of 96, PCO2 of 38, bicarb of like 15, and the lactate of like a 14. I'll tell you, we had given the same scenario in the mock exam as well. I think only one or two candidates actually answered this right. The most of them actually told it's a sepsis. No, it is not a sepsis. The patient who has got peripheries are pink, it cannot be sepsis. And the one thing is, the patient has got high lactate in a span of 1 hour. It is not under sepsis, and it is cyanide toxicity. The supportive treatment is all decontamination and antidote, hydroxycobalamin under sodium thiosulfate. See, and you have to and correlate to what all the scenarios and they give, and collaborate with all the investigations and the images whatever they've given, and also with the scenarios, and then come to a diagnosis. And you cannot simply jump to the answer that okay, high lactate, a patient is in shock, it is sepsis. No, it is not like that. So then comes, we have a scenario with a 24-year-old female with polytrauma. She was improving, so but on day 20 of her stay in the ICU, she developed a new onset sepsis. This is the classical scenario of a calculus cholecystitis. Patient was in ICU after 2 weeks or 3 weeks, and the new onset under sepsis, either it can be ICU acquired sepsis or something with abdomen. In the sense, uh, they might give you in the scenario as mainly right hypochondric pain. Patient is not tolerating feeds and all that, and a CT abdomen was done, which shows this. You can see the gallbladder wall is fully edematous, and there is no stones and all that. It is J calculus cholecystitis. Depending on the patient and the status, you will go for conservative management or percutaneous drainage. And the hemodynamics and the ventilator graphics is something so which will actually fetch you marks so easily. If you are perfect in that, if you have done like lot of in the practice, and you can fetch all, I think around under 12 to 15 marks. So, and you have photo of the monitor here, which shows about the arterial line and the tracing. How will you confirm your observation? What observation you can say? It is actually over damped arterial tracing. It is confirmed by fast flush test. It might look actually very simple for you guys, but you should know how to answer in the exam. Okay. And how do you actually confirm with a fast flush test? It is called reduced oscillations or absent oscillations here. So, and you have a scenario on a 12 lead ECG here. It's not actually on a 12 lead ECG. Okay. So the patient is undergoing in the CRRT on regional anticoagulation. Comment on ECG. What is the reason for abnormality? As soon as I see this, regional anticoagulation, I would think of on the complications of this and the regional anticoagulation. It can be mainly all hypocalcemia, the prolongation of QT interval. So then comes 68-year-old female with a history of the bullous pemphigoid and was on regular treatment since in the last like 15 years. Admitted for mainly hip replacement surgery, intraoperatively uneventful. The post-op hemoglobin was 10, WBC 15,000. The post-op day 3 fever and hypotension, echo normal, lung ultrasound A lines. Patient has got hyperkalemia, hyponatremia, hypoglycemia, hypochloremia. Bullous pemphigoid is actually a mainly hint here. The patient was actually on regular treatment. Bullous pemphigoid is a she she was on steroids. So patient was actually has got Addison's crisis. The treatment is actually all glucocorticoid or replacement. 38-year-old female, uneventful pregnancy in the postmortem and a sudden onset of the severe headache, neck stiffness, bilateral visual changes, ophthalmoplegia, like brought into the ER in hypotension, blood sugar 56, MRI brain shows cellular hemorrhage. Diagnosis is pituitary apoplexy and Sheehan syndrome. High dose glucocorticoids if no visual impairment. Urgent surgical decompression is required in those patients if there is progressive loss of the vision. So, and you have a 45-year-old female. See, you take it from me. If you have a scenario with a thyroid, the profile, make sure you see the T3, T4, and the TSH. And most of the time, the answer will be CQ thyroid. Though they might give you a scenario with all around 6 to 7 lines to just kill your time. The most of the time, and the answer will be CQ thyroid. Okay, so and he has sustained multiple long bone injuries. He was actually unresponsive in the field and he was intubated for all airway protection. And then he has got on day 2, he undergoes under surgery, the post-op, and we were actually like failed to win. He was evaluated in detail, and these investigations and shows free TSH is actually normal. The free T4 is in between the normal range. Total T3 is actually very low. It is CQ thyroid syndrome, and the low total T3 is associated with actually normal T4 and TSH. If you have there is absence of high TSH, it actually mainly all excludes the primary hypothyroidism, and there is no active management and for all this, and you just treat the source or any illness whatever the patient has. So the 56-year-old female who has got excruciating headache, altered level of consciousness, diagnosed to have SAH because of the aneurysm. She was operated for the same, and even full the conscious oriented. The 4 days later, she found to be drowsy. She's got a raised hematocrit and abnormal electrolytes, hyponatremia, potassium of 4.1, and the chloride of 90, and urine sodium of 49, and urine osmolality 145. What is the diagnosis? So she has got a raised hematocrit. See, they have not told you that she has got an increased and urine output or something. So they have put it as raised hematocrit, and urine sodium is actually like more than 10, and urine osmolality is around 145. It goes in like more favor of cerebral salt wasting syndrome. And SAH is a like very odd topic in these exams, and you should know all the complications of SAH, how to diagnose it, and which day of the post SAH, the first 2 days, which all the complications you expect. From the 48 hours to 7th day, which all the complications you expect. From the 7th day to 15th day, what all the complications you expect. And you should be aware of all this, and you should be actually thorough of all this, how to diagnose them. So how will you manage? Same with the isotonic in the fluid. And you have an ECG here. The 32-year-old man was presented with complaints of in the fever and dry cough. And the ECG was done as a part of initial evaluation. So what you can see in the ECG, it's all the right axis deviation, mainly the negative and the QRS in lead 1 and the positive in all AVR. So it is absent R wave or progression here. So it is dextrocardia, or sometimes because of the lead reversal. All this is to give a gist of all the CBS and the CCS. I'll just see the chat if you had any questions. Will they ask for the dose of the steroids and heparin? Yeah, so if it is the patient has got a pulmonary embolism or the fat embolism, and you should be aware of the dose. And the steroids, I think most of the time, so we use and the steroids only for the septic shock and other things. So and if you're aware of those doses, it's like more than enough. I think Tapas has answered, I think, most of the things.
Yeah. So I hope the session was useful to all of you, and definitely you should be thinking very seriously to start your EDIC to preparation from 2025 January, I think the first day itself, so that every day is someone like no something you should be like no not missing to start like no revising something that you have read in your training period. And if you have any queries or any doubts or anything which we would be like clarifying, please don't hesitate, and you can post in the group. We have a dedicated WhatsApp group also for this webinar, and we will be posting some or other like the future information as well as the details about our upcoming webinar, which we are planning to have analysis of the last session's questions and the trend of EDIC 2 currently. So that would be the next one. So we will be compiling all the things in our next upcoming webinar. So Sanant, if we want to add anything before we close.
No, Tapas, I think Manjunath has done a great job by going through so many questions in a short time period, but it gives an essence of what we are going to do in next 4 months or 3.5 months. So it'll be a bit rigorous, but it's worth it, and there is no other way around it. So you have to be prepared for the exam, because this is not a easy exam to crack. So it is pretty hardcore, and the preparation has to be to the level that is required for the exam.
Yeah.
Um,
And
yeah.
this is the structure of the exam. Like it starts from the 11th January, and we will be sharing all the resource materials related to cardiology. And then 13th, there would be the mock test. We are giving 4 days or 3 days for the mock test to appear, because we all understand that you are all busy in your clinical practice. And then on 17th, we'll be having live debrief. as Dr. Manjunath, Dr. Sanand has repeatedly told, the live session is something you should not dare to miss, because people normally think that we will be get the recording of the session and we will be going through, but it never happens in that way. It is formatted. The live session is for discussing live with the examiner as well as also with your fellow colleagues. So it never happens in your the time when you are least concentrated to your cardiology debrief. So you'll be taking the session bits and pieces. So that is not the essence that we are actually doing it. The whole reason of making it live, we could have done with recorded session also and providing it in your respective Google folders. But we never do that because the live sessions bring that stress as well as the exam. The I would say the environment is simulated and we normally engage our candidates in the discussion. So that is the whole idea. Now again, the sessions would be continuing cardiology, cardiothoracic surgery, neurology, sepsis, trauma toxicology, respiratory, onco, pregnancy, burn, drowning, nephrology and endocrinology, GI, hepatology, ethics, organ donation, communication, hemodynamic monitoring, miscellaneous, and finally 3 sessions of mock exam, which would be live 1-to-1. So thank you very much. If you do not have any query, so we are winding up now, and thank you, Dr. Sanand, Dr. Manjunath, Dr. Jitendra. Dr. Jitendra could not join because of his some commitment before, and all the invited faculties, like our successful candidates, and all the delegates, all the attendees who have joined from across the world. So thank you very much. Stay tuned for our upcoming announcements. Take care. Merry Christmas and Happy New Year in advance.
Thank you all.
Thank you.
Happy New Year to all. All the best.